I'm happy to introduce Dr. Locke, who serves as Jefferson County's Public Health Officer. And I've asked Dr. Locke to join us today to speak a little bit about what the opioid epidemic is and Jefferson County's response to the evolving landscape. And Dr. Locke, I'd like to start, perhaps you can get us all to the starting line in this discussion by explaining what does it mean to say that the United States is experiencing a national opioid epidemic?
Well, that's an interesting term, and I think in this case it's a very accurate one. The term epidemic is borrowed from an infectious disease problem, an infection that spreads through a population that's susceptible to it, like a flu epidemic or a black plague epidemic. And whereas people often use this inappropriately to describe social problems, this is a true epidemic. This is something that's spreading person to person through our society, and not only has a lot of features of an infectious disease epidemic, but a lot of those same tools that we use to control infectious disease epidemics we can use to address this one. So it's a problem. Opiates have been around for a very long time, thousands of years. There's nothing new there. We've known that they can be harmful and addicting, but things have actually changed, especially in the last 20 years. We've seen a dramatic increase in opiate use, and part of that has been that these drugs have been very heavily promoted by their manufacturers. Part of it is that physicians have not fully understood how dangerous the drugs are, and also how relatively ineffective they are for controlling chronic pain. So that's been a driver. And then on top of all of that has been what I would call the failure of the drug wars, or the criminal justice approach to treating addiction. We've tried in this country for 70 plus years to criminalize addiction with the hopes that would wipe it out. And in fact, what it's done has created this market for drug traffickers to explode the supply of drugs on the market. And in the case of opiates, it's been very cheap, very available Mexican black tar heroin. So especially over the last decade, we've seen a rapid spread of this, and then as the criminal justice system has tried to crack down on its import, that has led to an even more deadly synthetic form of opiates called fentanyl, which is completely synthetic. It's made in a lab. It requires no opium poppies, or it's very concentrated, so it's easy to smuggle, and that's actually becoming the leading cause of death with opiate overdoses, this synthetic fentanyl. So all of these things working together have created a problem that's had huge impact across the country, and including here in Washington State. Our neighboring county of Clallam County is one of the hardest hit in the state in terms of opiate death rates.
So how then would you say the opioid epidemic is affecting Jefferson County, and why is it important for us to have a focused response to it if we're already working on a national level?
Well, all of the ways opiates can harm people, and I'd say at this point that the essence of addiction, how we define addiction medically, is not just that you're physically dependent on a drug, but it's also that physical dependence plus the harm that it's causing in your life. So the way it harms your health, the way it harms your relationships in your family, the way it can harm the community at large. And we see all of those things in this community. We see the hepatitis C transmission that's associated with IV drug use. We see the disrupted families and the loss of child custody and the incarceration and criminal justice issues, especially burglary. the leading driver for residential burglary is people seeking money to pay for their drug addictions. And we see impacts on the healthcare system. People presenting to the emergency room in heroin withdrawal or with IV drug use associated infections, heart valves and skin infections, wound infections. So we're not as hard hit as other areas of the country, but we're also not immune to these harms.
So how does the work that we're doing here in the community dovetail with work that's being done on the opioid front in, say, the Olympic region, Washington State and federal level? How are we puzzle piecing our way in?
Well, in this state, because we were one of the first states to be not only hard hit by this, but also to recognize it. Washington State was one of the first states to recognize that the death rate, the opiate overdose rate was on the upswing, and at the point that it exceeded the motor vehicle accident death rate in King County, it really got our attention. And that was in about 2008, 2009. So in many ways, I think we're ahead of the country, probably 2 to 3 years ahead of the country in terms of a coordinated state, regional, local strategy. And now we see the nationally, the national response plan is very similar to what Washington's been doing for some time, and that is to focus on 4 main areas. The first is prevention, is to try to reduce the number of people that are getting addicted to opiates, to try to decrease the overprescribing of opiates by physicians and other practitioners. Number 2 is treatment. The only good news about the opiate epidemic is that it's a very treatable condition.
So do we have, like here in Jefferson County, I know you've got some charts there that might tell us a little bit about, for instance, the syringe exchange program. How does that give us some clue of how many people we've got that are dealing with this, and have we seen a rise?
Well, yes, and that actually falls into the third category. So we have treatment, and then the third category is harm reduction. And just for completeness, the fourth category is we need a lot better information. So we need to do a better job of collecting information, making sense out of it, and using it to guide our strategies, using it to tell us what's working, what's not working, how we can do things more effectively. But in terms of syringe exchange programs, which is something Jefferson County's been doing since the early 2000s. We were one of the first rural counties, not only in Washington State, but in the United States, to offer syringe exchange. And we do it it's for harm reduction.
I see.
We don't think shooting drugs is a good thing. In fact, it's catastrophically dangerous.
Yes.
But we can reduce the harms of that if people are using clean needles. We can reduce the harm of people being accidentally exposed to contaminated needles if we have an incentive for people to bring in contaminated needles and exchange them for clean needles. And then the third thing, and I think it's becoming more and more important, it's an opportunity for trained public health workers, mostly public health nurses, to have face-to-face contact with IV drug users and help them reduce their risk associated with their drug use, but also when the time is right, help them get into treatment. And as we expand treatment for opiates, which is actually a much more treatable addiction than, say, methamphetamine or cocaine or some other addictions, even alcoholism. We have a very effective treatment for opiate addiction. We just haven't been using it on a wide scale.
Right. It seems like I remember hearing that maybe between 2016 and 2017, we had quite a rise in the amount of needles that we were giving out. Is that?
Yeah, so our experience parallels what's been going on around the state. And just in numbers wise, so 3 years ago in 2015, we were at about 35,000 syringes a year, and that's in a county that at that time had around 30,000 people in it.
That's pretty significant.
That since that time, the numbers tripled. So we're currently at over 91,000.
Wow.
And these are real people, who we get to meet and talk to and ask, among other things, what drugs they're using. The other thing we've seen over this time period, actually over the last 10 years, is a movement from what was primarily IV use of methamphetamine. Now it's heroin. So we've seen this migration from methamphetamine to heroin, or even more dangerously, the combination of the two. So people that were injecting methamphetamine are now injecting both meth and heroin.
Wow. So there's a common perception that an addict is a person who doesn't want to recover, or even that this is just a bad person who's destined to make bad choices. And so I'm wondering, how does that square with what we see here in our community and what's going on across the nation?
Yeah, that's a big hurdle we have to overcome, is that stigmatization of addiction. And I think it's kind of a legacy from our criminal justice approach to this. Since these are illegal drugs, the people who are using them must therefore be criminals,
Right.
and must be treated like criminals. But what science has shown us, and now the evidence scientifically is overwhelming, that these are people with a chronic disease. And the nature of the disease is, not only is it chronic, but it relapse is part of the disease. It's very difficult to stay drug free when your brain has been reprogrammed by an addicting drug. And so we've especially seen this over the last 5 years. There's been this growing consensus in the scientific community that this is no more a character defect condition than say diabetes, which has serious behavioral risk factors in it, as does heart disease. But we don't treat diabetics as criminals or people with heart disease, and we really shouldn't treat addicts as that, people with a brain disease. So we're trying to move this to more of a medical model for treatment, because among other things, the criminal justice approach, no matter how well intentioned, has objectively been a failure. Things are getting worse. We've spent billions of dollars. We have the highest incarcerated population in the world, proportionately, and yet we haven't solved this issue. Right. You can get heroin in prison, so it's just we're not going to solve it doing the same thing. We need to do something different, and doing something different is looking at addiction and the people who are addicted, who have what we call opiate use disorder, see them as people who are struggling with a chronic disease, and apply what we know medically and scientifically to the treatment of that disease.
So if I were to go right into the addict's mind, or how they're feeling, could you paint a picture for us of what an addict is experiencing, and how I, as a person trying to communicate with them, could be more successful at communicating with somebody who's going through recovery or experiencing addiction?
Yeah, that's an interesting question, and it's and I've had the opportunity, in addition to public health work, working as a physician treating heroin addicts. And one of the things I've learned is that there's enormous variation in the experience of addiction. You know, what are the factors that put a person at risk of addiction? How it harms their health and relationships? What their path of recovery is. There are common experiences, but there's probably a lot more differences than there are common experiences. Some people are, and I think the stereotype of an addict is someone who just does it for thrill seeking.
Right.
You know, it starts as a recreational use and then devolves into an addiction. But actually, in my experience, that's the exception rather than the rule. Most people, in fact, have mental health issues. They have trauma in their life. Rate of addiction in sexual abuse survivors is very high, for instance. In soldiers with post-traumatic stress disorder. Increasingly, we see people with chronic pain that's not well managed medically. They become addicted to prescribed medications, and then when they can't get the prescribed medications any longer, they move on to heroin. So the origins of the addiction are highly individual. Eventually, though, it comes to take over a person's life. One of the things we've learned about opiates as a class is they have effects much more profound than just as painkillers or drugs that make you feel good. The reason those things exist is because the brain has this pre-existing system called the endorphin system that not only regulates pain, but it's what's called the reward center of the brain. It's how we reinforce ourselves for doing things that are good for our survival, eating and exercise and reproduction. All of those things produce an endorphin response. And the drugs essentially hijack the system. So they take over the reward system, they shut down your natural production of these chemicals and leave you completely dependent on the drug to provide this really fundamental sense of well-being and freedom from pain and distress. And so increasingly people's lives are taken over with this compulsive behavior. The need to keep getting sources of the drug to prevent withdrawal from it. And then to make matters worse, it's the nature of the drug that people develop tolerance to it. So you need more and more of the drug to get the same effect. And eventually you need very high levels to just have any effect. So it's in that sense, it's a horrible addiction where you need more and more of it, and the withdrawal from it, if you can't get it, becomes more and more severe.
So this might be a tough one, but could you give us an example of how a more empathetic perception, if I have a more empathetic perception of an addict, how could that change the outcome of that person's path to recovery?
Well, that's a key thing, and that's something we're trying to educate healthcare providers, and is really I would probably use the term compassion more than empathy, but it involves both. It involves being able to put yourself in that person's shoes, at least to some degree, and get a sense of how hopeless they might feel and how stigmatized and worthless and powerless, really a slave to this compulsion, and in many cases how victimized they become.
Right.
You know, as they get drawn into the criminal system. You know, as you have to steal to supply your habit, or trade sex for drugs, or do all these sort of demeaning, depersonalizing things. So people sink very low, have very low self-esteem, have a very nihilistic approach to life ultimately. I've always regarded it as just this notion of buying a bag of a black tarry substance on the street and injecting it into your vein and not knowing whether you're going to survive that or not is about as nihilistic as you can get. So you have to understand where people are coming from, and if you can suspend your judgment and you can open up to them as a person, you're also opening the door to their recovery, because if they can rediscover their self-worth and understand that there are people there who want to help them, and help is available. They have a treatable illness. The treatment's not easy. It's going to be a lifelong struggle, but it can be a successful struggle. And those of us who get to work with the treatment of addicts, it's one of the most gratifying areas in medicine. You see people just completely turn their lives around, and get their kids back and go back to work and go back to school and get their families back together and these things, just completely turn their lives around. And the truth is we don't see that a lot in medicine. A lot of the things we treat, we're holding the line. We're trying to slow down the progression of a disease, but this is a true treatable disease. So it's a challenging thing for people to confront their own biases and preconceptions, and especially at the point you may encounter a person. If you encounter them, at the height of their uncontrolled addiction, they're not often a nice person to be around.
Right.
They may be deceitful and manipulative. They may want to steal from you. They may have lost control of their behaviors, so they're not their true self at that time. It can often take weeks or months of treatment before you finally meet the real person that's underneath there, as the drug no longer has control of their brain. Then you start to discover who they are and what their potential is.
I wondered if we could just talk a little bit about what is the treatment for somebody who's going through, who is an addict, who would like to be recovering. I know that we have a couple of resources in this community that can be applied to that, and I wondered if you could tell us a little about that.
Well, with opiates, not everyone has full-blown opiate use disorder. So, for some people, they can stop. Who are physically dependent on opiates, they can wean off of them, and with supportive therapies, they can stay off. But one thing we've learned about opiates is, especially with long-term and high-dose use, the changes in the brain are profound, and in many cases they may be permanent. The changes occur right down to the genetic level. And so increasingly we've looked at that as a chronic, lifelong, relapsing disease. And the most effective treatment for that is to replace the missing drug. Your brain used to produce endorphins, but does so no longer.
Right.
And so we give special synthetic opiates that don't make you high, but they replace the missing endorphin, and they prevent the physical craving for the drug. So they give us that window of opportunity to then start addressing the other mental health issues, the depression and anxiety, or
so it's not just that we give them a replacement drug and send them on their way.
No, it's a starting point. We've learned that without that, even the best treatments, the best kind of talk therapies and group therapy, abstinent treatments, have about a 10 to 20% success rate, as measured at relapse-free after a year. And the opiate substitution treatments in their most effective forms can have success rates approaching 80%.
Wow.
And that's a huge difference. And when you're in the midst of an epidemic, you want to use your most effective tools, not your least effective.
Right.
So we've learned that long-term treatment, often with very low doses of drugs like buprenorphine, and a brand name of it is Suboxone, is what it's most often known as. These, along with mental health counseling and substance abuse treatment, can be very effective in kind of helping people take back control of their own brains. And we don't see it as a cure. We liken it in many ways to insulin for a diabetic. Insulin does not cure diabetes.
Right.
It just replaces what's missing, and it allows a person to lead a normal, healthy life.
Right, and that's what we're doing here. Suppose, Dr. Locke, I run into somebody who is obviously in the throes of an addiction behavior. What is the best thing for me to do? What resource do I have to offer them? What should my next step be?
Well, that can be a very difficult situation to be in, because it's these are drugs that profoundly affect your behavior, and often for the worse. So people have a right to be safe, to be free from violence, to set limits on abusive behavior. I mean, just because you're addicted to a drug, you're not absolved from those rules we have in society. But I think that experience is much like the experience we have in our syringe exchange programs, where we have people who are actively addicted coming in, not to end their addiction, but to actually have us help them by giving them supplies to reduce the risks of IV drug use. And our approach, and I recommend this for others, is to be respectful of people. They're used to being treated with hostility and judgment and bias, and just not doing that, treating them as a fellow human being. And if you have the opportunity, if you see an opportunity to help them, to let them know that there is treatment, or to say, you seem to be having a health problem. Do you need help getting care for that? That can go a long way, because even at the depths of addiction, people are still human beings, and we're social animals. We want to be accepted by others. We want to exist in this kind of community milieu. But it can be hard if someone's being disruptive.
Right.
And I don't think you do anyone any favors tolerating that. But if you can combine the necessary response to unacceptable behavior with the offer to help people, or help guide them to treatment resources. And this is something we hope to do a much better job of in the community. We've got a number of regional and county-based programs that we're trying to ramp up to make treatment more available. I'd mention one other thing that may have impact to library staff and others who work with members of our community who specifically are using IV drugs, and that is the risk of overdose. So something we do in our syringe exchange programs is distribute the antidote to heroin overdose, the drug naloxone. And
Mhm.
we really targeted public safety workers, emergency responders, family members, people with addiction. But it applies to the whole community.
Mhm.
You know, knowing that there is an antidote, you know, in many cases the IV drug user will have it with them.
Mhm.
But knowing that there are drugs you can administer either by a intranasal spray, or there's even a form that is an injectable drug that can save a person's life.
Mhm.
Just like CPR can save a person's life in the event of a heart attack. Knowing about how to administer the life-saving antidote to heroin and fentanyl overdose can save a person's life. And this is not a theoretical thing. We see this happen in the community. That we have distributed over 100 naloxone kits through our syringe exchange program, and we've only been doing it for a little over a year. And we see people coming back for refills of those kits. They've
Which means
used
they've
the
been
drug.
used.
Yeah.
Mhm. So just to make sure I understand correctly, you're saying that when I get a syringe exchange, when I go through, if I'm an addict, I get syringe exchange, I can also get a kit that's a sort of an antidote if somebody near me was overdosing. Okay, so then one other thought I had is, if I'm a person who does not look like a drug addict, but I know I'm wrestling with it, where do I go if I don't particularly want to go where everybody else is going that does look like they are addicted? Does that make sense?
The system we're trying to build is one where everyone has a medical home and all of their healthcare needs can be met in that medical home. I think that's really the ideal.
Mm-hmm.
And I think we can get there
Mm-hmm.
as we destigmatize addiction, as we make it more of a treatable chronic medical problem. I think the barriers will come down.
Mm-hmm.
But right now we're not at that ideal point.
Mm-hmm.
And some people want to keep their medical care experience and their chemical dependency treatment experience separate, and it's possible to do that.
Here in this county.
Yeah, there are people who just provide only addiction services. There are chemical dependency programs that focused exclusively on the opiate addiction.
Mm-hmm.
Our challenge is to getting all those programs working together.
Mm-hmm.
So medical prescribers, the ones who can actually legally prescribe drugs like buprenorphine,
Mm-hmm.
the substance use disorder providers, as we call them, the SUD providers,
Mm-hmm.
And then very often mental health professionals have a key role to play in all of this. There very often is anxiety or depression or
Mm-hmm.
post-traumatic stress disorder. There very often are chronic pain issues,
Right.
or altered perception to pain, and so it's a complex disease process, and we need everyone working together, and that's our model in this region.
Mm-hmm.
You know, we have a steering committee that actively represents all those different provider groups, and we're trying to develop new and better ways to work together on this common problem.